I want to introduce our morning keynote speaker. Robin Gelburd is the president of Fair Health, and Fair Health has become quietly, I think, sort of the nation's all-payer claim database. That's not quite right. That's a little more than I think Robin would say it, but it's moving in that direction. Last night at dinner I said, so you guys have about 2 billion paid claims in your database. And she said, yeah, but we also have 52 billion more. We have about 54 billion paid claims in our database. That's a huge amount. And from that data, they can do some really interesting analysis to drill down on Texas healthcare, to talk about pricing, to talk about utilization, and provide a window into the system here that no other entity can do. So let's give a warm welcome to Robin Gelburd of Fair Health.
And we're really excited to have our data contribute to that constructive dialogue for reform that DJ was speaking about. So, before we dive into the data about Texas, and there are a number of unique characteristics to that data, so I'm excited to share it with you, just wanted to let you know a little bit more about Fair Health. So Fair Health is a very unique organization. We were created back in 2009 out of an investigation by the Office of the New York Attorney General into certain conflicts of interest that were perceived to be in data used to adjudicate claims. It never went to trial. Everyone agreed that a new independent not-for-profit should be created that could bring transparency and integrity to the health insurance marketplace, if you will, and to create a repository of data that was robust, transparent, with the best thinking of statisticians and economists in terms of the methodologies used to validate the data, and have that data populate data products and solutions and a consumer website and policy-making instruments that could really advance the dialogue underway in the country. So it's very unusual. You don't typically have an investigation give rise to an independent operating entity. And so overnight, in effect, a New York investigation gave rise to a national remedy. And because of our unbiased status, we sit squarely in the middle of the healthcare ecosystem. And we really welcome the input of all the different stakeholders, because that really helps us inform our work and bring the most important data products to the market to really help advance sound decision making. So what do we have? So DJ is correct. We now have 27, in fact, over 27 billion commercial claims. That's coming from both fully insured and self-insured national and regional payers and third-party administrators. It essentially captures the healthcare claims experience for about 150 million covered lives. And when we receive that data, we organize it into very granular geographic regions we call geozips, which tend to track with the first 3 digits of a zip code. So that allows us to really capture the heartbeat of the medical market. Texas, for example, has 30 geozips, which, as you can see, is much more granular than the 8 geographic regions that Medicare uses. So we could really see quite visibly into the granularity of that area. In addition to our commercial data, we have been entrusted with the entire collection of Medicare Parts A, B, and D by CMS. So we are now a certified, qualified entity. That allows us to really do some interesting analyses, public and non-public reports that compare the commercial and the public populations, which allow for some really interesting analyses. Because of our neutrality, many states have reached out to Fair Health to serve in an official or quasi-official capacity for various health-related programs. For example, we serve as the data source for many workers' comp fee schedules across the country, auto liability fee schedules, dispute resolution programs written into the California Healthcare Code, for example, regarding emergency services. And increasingly, we have been playing a very big role in the debate roiling the country about surprise balance bills. We are already officially used in New York and Connecticut as a benchmark to help resolve those disputes. The federal government right now has a bipartisan group of senators that have developed a bill that's also referencing a data point from Fair Health's repository. And we are assisting over 20 states in sort of noodling through the implications of going in different directions to help bring protections to consumers while fairly compensating providers and protecting all stakeholders. In addition to our state role, we also play a very large role at the federal level, both in terms of bringing insights into different clinical areas, whether it's food allergies, Lyme disease, obesity, and diabetes, and particularly the opioid crisis. And we also have been selected by the Bureau of Labor Statistics to give them a monthly feed to help them with their medical CPI indices. So really, with this ocean of claims, our goal is really to bring people out. Think of it as being on a glass-bottom boat, because we want to change that sort of opaque ocean into something everyone can see in and see the trends and seismic shifts that we're seeing as we collect these billions of claims. So now the fun part, we're going to go to Texas. So one of the seismic shifts we're seeing is in where people are accessing care. There's really a major revolution in the healthcare system underway right now in terms of alternative venues that patients are seeking out, whether it's retail clinics, urgent care centers, ambulatory surgery centers, telehealth as well. And so I thought it would be interesting for you to see how Texas stacks up to the nation in terms of some of those changes. So in terms of understanding some of these graphs I'll show you, let me just explain. When we look at 2009 to 2017, what we've done is we've isolated all of our claims with a geographic region in Texas that have a flag on the claim that's a retail clinic, because that's a special place of service. And we compared how those claims are trended over that period of time. And as you can see, there's an 11,000% increase in Texas in terms of availability and use of retail clinics. And what's behind those numbers? A couple of things. More than 1/3 of retail clinics are located in one of 5 states, Texas being one of them. Walmart care clinics have also used Texas. It's one of 3 states where they're prominent. So that's another sort of outpost in Texas. The other thing is, in terms of primary care, I think, as you probably all know, being more local, but studies show that there are some underserved areas in Texas, and primary care access is an issue. And so the retail clinics have now stepped in and are providing a number of services that might otherwise have been provided in a more traditional primary care setting. And here we thought it would be interesting for you to see the types of diagnoses that typically present in a retail clinic. And as you could see, particularly when you see things like chronic respiratory conditions and issues, when you see chronic, that's something, again, you would typically see in a primary care setting, so people are returning to these retail clinics for that type of primary care. What's also interesting, you see office visits listed. Again, in the past, what we would see in our claims for retail clinics would be mostly vaccinations, the flu vaccine, shingles vaccine, and so forth. We are seeing office visits around the country, and you can see that's prominent in Texas. And interesting, behavioral health is also listed here. Again, in Texas, some of the Walmart clinics are offering mental health services, something new to a retail clinic setting. Here, it's looking at the difference between Texas and the nation. And as you can see, there are certain things that are different and certain things that are the same. For example, the acute respiratory issues are the same, but below that, you could see there's very little commonality. And again, what's on the Texas side would again indicate that this has become an important primary care outpost. Retail clinic usage. This is looking at the different age cohorts associated with retail clinics. And what's interesting is you can see that 41 to the 50-year-olds are prominent, or 41 to 60, because they are, which is unusual to the nation. And what we've learned too is that when you look at Walmart studies, the typical shopper is 50, which may be an interesting reason why it is so stacked in favor of that age cohort, which is somewhat different than the age variation in the nation. Let's turn to urgent care usage. Another important outpost in Texas, as you could see, there's been over a 1,300% increase in utilization in urgent cares, which rather outdistances what the national data are showing. And again, this is an example, and when we see the diagnoses in a moment, you'll see how much the urgent care tracks what would be typically seen in a primary care setting. And what may explain the leveling out in the later years in Texas is the freestanding ERs, which again is a unique feature in Texas, and it has been siphoning off some of that urgent care utilization, although as you could see, it still is playing a very large role. So again, acute respiratory infections, as well as influenza, urinary tract infection, these are really the top. But you could see by far dominated by acute respiratory infection as the main diagnosis that is presenting on claims associated with urgent care settings. And now let's compare Texas to the nation. Again, what you see on the left-hand side in terms of Texas are the chronic respiratory conditions presenting, which is showing how people are really trying to find their way to get some access to care for situations as well as skin conditions and so forth, and influenza. Interestingly, while the diagnoses vary between the nation and Texas, the cohorts exactly in terms of age distribution mirrors the same. And that's not surprising. With urgent care, it's typically parents who are bringing young children in when it's after office hours or of serious concerns, and young children are often subject to acute respiratory infections. So great parity there with the nation. If we look at ASCs now, you could see that Texas ranks number 3 in terms of the number of ASCs in the country. This is as posted in June 2018 by CMS. Again, not surprising, Texas being number 2 in terms of population in the country. So not surprising that it has become a prominent source. With respect to ASC utilization, pretty much tracks exactly what's happening around the country, not a material difference there. Nor is there a material difference at all in terms of the age cohort. And as you could see, 51 to 60, that age tends to around the country be the dominant age accessing ASCs, and that's easily explained by what's typically occurring in ASCs. As you know, that's an area where people would typically get an endoscopy or a colonoscopy, and that would be the age bracket that would typically access those types of services. All right, let's go to emergency room utilization. In Texas, it's really interesting. These numbers somewhat really camouflage some of what's really going on under the hood, if you will. You could see Texas is slightly lower than the nation in terms of the trending, but the blue line being Texas has flattened out a bit, and that's likely because of, again, what you saw with the urgent care usage really taking a large part. And when you look at what's happening in the ER in Texas and the urgent care center, oftentimes it's very similar. So these are the top diagnoses in emergency rooms in Texas. And what really strikes one is look where cardiac events are on that list, way down. And that is very unusual. When you look at the nation as a whole, cardiac event is number 1. And when you look at individual states, most states would have cardiac event as being the single most prevalent condition presenting in an emergency room. And so this is where Texas's unique personality and character plays into the data because of the freestanding ERs and because cardiac events typically do not present or get treated there, because 90% of the time, based on statistics, there's usually an inpatient stay associated with someone presenting with cardiac concerns. They would not be going to the freestanding ER. So you have a very different array of diagnoses presenting in Texas as you do in the nation. The other thing that's really notable in Texas is look at the age distribution. Again, somewhat anomalous from the nation as a whole, and when you look at a lot of individual states. For example, I had the privilege of being at the Washington State of Reform Conference, and there the data would show 70 and over is really the dominant population in emergency rooms, and the older population is typically most reflected. But here you could see it's a large sort of middle-aged grouping as you see that flattened out group from like 31 to 60 or so. And again, what that might be suggesting is the freestanding ERs serving as almost a primary care outpost where people are going potentially for non-emergent care, a very different utilization age distribution that you will see. Let's turn to behavioral health for a moment. Because we're coming now and just past the 10-year anniversary of the Mental Health Parity Act, Fair Health has been doing a lot of analysis on behavioral health data around the country. We thought it might be interesting for you to see over the course of those 10 years, from 2007 to 2017, what has occurred in Texas in terms of trend lines for all claims associated with both mental health and substance abuse. And so we both compared Texas to the nation as a whole and just picked out a couple of states to give you a reference point. And as you can see, Texas is really in the middle of the pack there in terms of the increase in claims seen over those 10 years. And when you look at the data, again, we can reflect utilization changes, we can reflect diagnoses and costs and so forth. What's really always interesting is handing the baton to health system researchers to understand what the data are really showing as you delve down more deeply. Think of it as we'll take you snorkeling, and then we love to help people really scuba dive down into that ocean of claims. And when you see utilization levels, sometimes it can mean either that there are the care is not needed, there's not a need for the care, or it could be that there are access issues. There could be cultural norms associated with why someone is or is not accessing care. So it's always interesting to really look beneath the numbers. Here are the diagnoses that are most typical in Texas presenting, and you could see major depressive disorder ranks 1 above substance abuse related issues. And as you could see, that is flipped in the nation. The nation as a whole has substance abuse claims that are much more dominant and skewed in favor of that type of service, with major depressive being below that. So really sort of an inverse. And you may understand why in a moment. Here's looking at the behavioral health age distribution, really fascinating to us, because look at that over 60 column in Texas. Very, very different than the nation as a whole. It was so interesting to us, we said, let's look and see what are the diagnoses associated with that over 60 population. So the top diagnoses are depression, dementia, general anxiety, and substance abuse and bipolar disorder, which is a really interesting, sort of litany of diagnoses, and I think it really invites some interesting studies going forward. You could see how it departs from the nation's profile. So the other thing that's striking here, let's turn to telehealth. So telehealth, actually, which has become a big outpost around the country for mental health services. As you see, we're only plotting one line here, which is the increase in the nation, which is 1,500% in telehealth. Texas is not plotted here because the claims were really de minimis, and I understand there's been some new legislation recently passed that now allows the establishment of a patient-provider relationship in person as opposed to requiring it, virtually as opposed to requiring it to be in person. So we're going to track that and see how that legislation will really impact utilization in the state, and we'll certainly keep you apprised of those changes. Let's turn to cost now for a moment. One of the things that Fair Health is asked to do frequently is really track trends in pricing. We look at pricing in very different ways. We have bill charges, what is actually billed by the provider in the non-negotiated environment. We have the allowed amounts, which is the negotiated, in-network amount, if you will. We look at it at the state level. We look at GeoZip pricing. We look at regional. And so we're always looking at it through different prisms and at different percentiles and levels. Here, just as a point of comparison, we picked the 80th percentile of bill charges of a common office visit. We chose the 80th percentile, even though Fair Health offers a whole variety of percentiles, because that's often incorporated into different reimbursement models. And as you could see, over the course of the 4 years, incremental change, not really a dramatic increase. This is at the state level. Here we're looking at an emergency code, again, over the 4 years at the state level, again, not an overly dramatic increase over time. Now we're showing you a different way to look at the data. So here we're showing you the 80th percentile of billed charges, the 50th percentile of billed charges. Then we've picked the 125% of the median allowed amount. the median negotiated amount, if you will. The reason we pick that is because that is currently the placeholder in the Senate bill that is being drafted and considered in connection with surprise billing, and then compare that to CMS, comparing Houston and Dallas. So you can get a sense of how there's variation in the data. We see wide variation in sort of contiguous geozips across state lines. There are always interesting explanations for that, but it also brings home the fact as to why the geozip configurations really allow for deeper analysis. Here again is looking at another emergency code that is urgent severity, and this is now throwing Austin into the mix as well, looking at it again from the 80th percentile of build to the 50th percentile to the allowed formula to CMS. And again, keep an eye on that CMS number because as you know, CMS is a federal fee schedule that embodies in it certain policies. You could agree or disagree with those policies, but it doesn't purport to necessarily reflect the commercial realities on the ground in terms of negotiating powers and economic winds that are blowing. Here again is another, here's a psychotherapy code, which factors prominently in the out-of-network conversation. It often is a service that is accessed out of network and is often subject to questions and concerns by patients. But again, look at that CMS number. You could see there it's much closer to what the allowed or negotiated amount is, again, reflecting that that fee schedule sometimes aligns with certain factors on the ground economically, and sometimes it's embodying a federal policy that may reflect a particular specialty preference. Let's turn back to opioid abuse and dependence, and this goes back to what we were showing earlier in terms of the data, in terms of the diagnoses. So what we've done is we've done 4 white papers in the opioid crisis that have really gone down very deep into what are the trend lines in the country, looking at age cohorts, demographic factors, geographic areas, and looking at pricing from both an allowed and a billed amount. In our very last opioid white paper, we took a 50-state analysis and we looked at what are the top 5 most frequent services rendered to someone with an opioid abuse or dependence diagnosis, and what are the top 5 most expensive cost centers associated with those services. So here we're just comparing, showing you Texas, Arizona, California, and New York. Where the colors are the same, that means it's the same procedure code. And where there's white, it means there's no comparison at all. And as you could see in Texas, when you look, what was interesting to us, and if we showed many more states, it would similarly be true, Texas uniquely stands out in that most of the services are associated with drug testing. There is a 15-minute, and there are 2 office visits, as you could see, reflected, but in the other states, you'll notice there are more therapeutic services offered, whether it's group therapy or intensive outpatient or methadone maintenance. Very different scenario when you look at Texas versus others. And that's also true by cost. When you look at costs for Texas, it's all drug testing, whereas when you look at the other states, a number of their costs are associated with outpatient services, group psychotherapy, individual psychotherapy, methadone, different kinds of medication management. So it's a really interesting phenomenon in Texas that certainly caught our attention. And now also wanted to show the other way in which we striate the data and look at the data are what are some sort of anomalous findings. So sometimes we'll look at population density compared to what the utilization is for particular conditions. So here on the top, you could see that that reflects the population distribution in Texas, with San Antonio having 5% of the state population overall. But look how it compares to the utilization in claims associated with opioid abuse or dependence. So again, this is just to show that the data can really, if you peel it back, can reveal some really interesting trends and allows you then to ask the next question and the next question. Okay, well, I'm happy. I know DJ is going to have some questions, and I'm happy to take any of your questions as well. Thank you.
I'm just tweeting out that last slide deck here. Hashtag state of reform for all of you out there. San Antonio, good Lord. What, I mean, I know if I ask the question, what's happening in San Antonio, that you're not the person to answer it, but that is really striking. Is that I guess maybe that's common, that certain communities in different states really have a spike?
And it's interesting because I know you mentioned this is not a destination type conference, but there are some destination states and communities for drug services. So, for example, Delray in Florida, as you may know, attracts a number of people coming for treatment there. There may be, and that's again what I said, it's always fun to hand the baton on and look in San Antonio, are there drug centers or rehab centers or types of facilities that people are coming and being, attracting people from other parts of the state or even across state lines. So that's always a fascinating sort of next question to look at.
Tell us more about what you saw in the data and your, your sense of things vis-a-vis freestanding ERs. I heard you, because that's a very active point of policy discussion here. It's an active point of market activity. I heard you say that you think that there's a correlation between the number of freestanding ERs and an increase in otherwise primary care-related codes or claims delivered at the ER setting. Is that, what else can you tell us about that?
Yeah, I think, the freestanding ERs raise or bring in another wrinkle to this whole burning issue about surprise bills and the lack of transparency in pricing. Already, emergency services, not even connected to freestanding, have become a real pain point for consumers. You're hearing about, large bills, and when you think about emergency, by its very nature, you cannot select an in-network facility at your choice. You may even be unconscious being taken in an ambulance. So then, add the freestanding ER to that equation, which may create some confusion in the minds of consumers about how that differs from urgent care centers, and they may not be aware of the cost structures of freestanding ERs, which will necessarily, to be certified in that way, have to offer certain types of equipment or services that would necessarily maybe cause a higher rate. And it's unclear oftentimes to consumers, are those in-network or out-of-network, and how do you really isolate those bills? So my guess is, and I'd be curious, and would love to learn more from those in Texas, how the issue between urgent care centers, which clearly are increasing here, and freestanding ERs, how they're finding their space in the healthcare ecosystem, and how it's being communicated to consumers when it's appropriate to access what type of venue and what kinds of questions they should be asking.
I want to make sure that you all can ask questions, so we'll have a microphone floating around, and Robin can take only hard questions from you all here in a second. But I want to ask if the sort of flip side of that might be true also, which is it possible that one could conclude that Texas is having a hard time just in basic primary care, and not just on the medical side, but also on the behavioral health side?
Well, I understand there's a RAND study that ranked Texas 47 out of 50 in terms of primary care access. So there is an issue with primary care, and it seems like people are finding their way to other outlets to get the care they need. Behavioral health is interesting. As I mentioned, around the country, telehealth is becoming more and more prominent. Not only does it allow individuals to access care at inconvenient times, that maybe during a work hour, so they want to do it after hours, or maybe people who are in rural communities or underserved communities access the care, but mental health particularly sometimes carries with it a concern about even reaching out for help at all. So it'll be interesting to see, with the addition now of behavioral health through telehealth and also in your retail clinics, which is a very unique feature in Texas, how that will cause people to really reach out and access care that they need. I also find the over 60 population really fascinating here, and there may be ways, public health interventions or other things that could be done to really focus in on that cohort, because it seems like that is a data point that is sort of inviting further scrutiny.
Questions here in the audience?
Yes.
Why don't you tell us who you are and your organization, and then
Sure, thank you. My name is Michael Dick, and I'm the CSO of Health Eye Medical Equipment, an independent company here in Texas and one of the owners. Thank you for making the trip to Texas, man. We appreciate you very much. A couple questions on your data and information. Did you guys take into consideration the continued population increase here in Texas and leave that information in or redact it out? And then secondly, are you able to understand the different plan types? And I ask that question because as a business owner, we've had to continue to manage our overall spend as far as our health plan for our own employees. And then that drives the education on how to use those specific entities you're talking about, whether it's the ER or the urgent care, that type of stuff. So I was just interested if you can see that granular inside of your data and information.
Sure, thank you. That was an excellent question. So we normalize the data year to year just to make sure that we're not introducing any skew that would be misleading. So that was a great question. As to the plan type, what we do is we can isolate HMO versus PPO and also often ASO, whether it's a self-insured versus a fully insured plan. But what we do offer, and we're happy to talk offline, we have, in addition to the free website that we offer in terms of data points for pricing, is a whole curriculum to explain to consumers what's the difference between urgent care and emergency care, what's the difference between an HMO, a PPO, and an EPO, really when to access different types of facilities, what the implications are, what questions to ask. So there's a whole educational sort of health literacy component to what we do, and we're always happy to make that type of material available. So we can speak offline about that, but you're right, consumers, it was fascinating. We once did a national survey with ORC asking consumers different questions around the country about their health literacy and all. And one of the things that was fascinating, over 77% of respondents said they wish they had learned about health insurance in high school or at least in college. And I know having a 26-year-old son who just got off of my insurance is clueless. And I realize how desperately in need people are of information about how to navigate that insurance highway. And so we try to provide that driver's ed, if you will, and feel free to reach out.
Hi, I'm Joe Ventimiglia. I'm with UT Southwestern Family Medicine. Our department is very interested in understanding and helping to solve disparities in healthcare access. My question for you then is your database available in any de-identified format to people who would like to access the information for research purposes?
Oh, absolutely. We make our data available all the time for research, whether it's looking at consolidation in the marketplace, whether it's looking at migratory patterns of patients, in every permutation of the healthcare system, yes, to the extent we can assist, we would be happy to. And what we do in that instance is just talk to, the individual or the organization to see what is it you're trying to look at or understand to make sure our data can address that question. And yes, we assist in that. That's part of our mission.
I'm Roland Gertz from Heart of Texas Community Health Center in Waco. I have a kind of a technical question. Having survived the last several years where our state has converted Medicaid to a managed Medicaid with multiple MCOs, it's my contention that claims are not always claims and that they're not always commonly put together with the same sort of methodologies, even though they should be. So the question is, you've got billions of claims. How do you cross-check or verify your analyst's analysis of that data? And do you ever have to throw out too many claims that you cannot interpret because they're not listed correctly the way your electronic analysis does that? Do you have two sets of teams look at it and see how they turn out? How do you do that?
That's a great question. So again, we're talking about commercial data here, not Medicaid data. We have done some separate analyses for Medicaid, but that's not included in our repository. And so what we're working with are the official claim forms that have specific fields that have to be filled in. But on top of that, our analysts and statisticians map every contributor to a standard vocabulary before it even goes into our repository. So we're comparing apples to apples, whether it's specialties, place of service, all different kinds of features taken from those standard claim forms. What we do is we do eliminate, for purposes of our pricing, but not necessarily for public policy analysis, outlier claims. We have an outlier methodology that removes extreme outliers from the data to make sure that it is not distorting the distribution of the data. And then once that is cleaned, it will go in and we'll also make sure that there are valid zip codes, valid procedure codes, and that it's the rendering zip code, not a post office box before it goes in to make sure we're capturing the right data for the right market. And that's a big, that's really what we do. As DJ said, in a sense, we are like a national multi-payer claims database. I would use that term instead of all payer because we don't have Medicaid in our repository, but we allow people within a state to make comparisons and across state lines to compare, make sure they're looking at the same features.
One of the things, Robin, that we're hearing, one of the implications of what we're hearing in terms of the policy space, whether it's a Medicare for all or a Medicare or a public option that some states are pushing that has a Medicare rate requirement for an otherwise commercial or individual marketplace. Some of the things we're hearing about is this sort of move towards a world with implications that we will drive some reimbursement from commercial down to Medicare. You had, I think it was a psychology or an MSW code that said essentially the paid claims was very similar, the commercial paid claim was very similar to Medicare. My hypothesis would be that as you move up the specialization ladder, as you move up the capitalization ladder and the market leverage ladder, that you get diversity or divergence from Medicare. Do you see a lot of primary care, behavioral health care, lower specialty care, maybe closer to the community, that has paid claims that are close to Medicare?
So that's a great question. There was a study that was done not too long ago by Milliman using Fair Health data, comparing it to Medicare, looking at it by specialty, whether it's allergy services, endocrinology, neurology, and so forth. Your hypothesis is exactly right. As you would compare the Medicare to the different specialties, so for example, against neurosurgery, it may be 30% of what the commercial rate may be. As you move down to sort of family practice, internal medicine, behavioral health, you start getting into the 70, 80, 90% parity in that data. So clearly it is encouraging certain kinds of services to be rendered at the expense of others. And again, one can agree or disagree with the policies, but it again doesn't purport to be reflective of what those commercial conversations are. And so yes, you would see tremendous variation in specialty to the ratio of what that commercial data would represent.
This is put you not necessarily on the spot per se, but I don't know that you have this answer at the tip of your fingers, but how does Texas compare to other states that you've done this deep dive in at the sort of allowed level, the billed or the paid claims level for a range of services? I mean, you put two of them up there, but compared to other states, is Texas a high-cost state for allowed claims or a low-cost state?
No, I would say the ratios are consistent with what we're seeing. Again, it would depend on the community. There are 30 different geozips in Texas, so there are different market forces in those different geozips, so it's hard to give a state number overall. I would say, again, the ratios are similar. There may be instances where Texas may command a higher allowed amount in certain areas where it's lower. It will depend on who the players are, what the specialty is. So it's hard to give a single simple answer to that.
There's a very reasonable argument that the more transparency there is in healthcare, the more that will raise prices because Harris County providers will say, look what's going on in Travis County and Austin, based on your slide, and Houston folks will want Austin rates. Do you find, how are systems, how are communities responding to the transparency you're bringing? Do you find people upset? Are they excited? Are they scared? Do you see prices going up? Do you see prices coming down? What do you see?
So that's a great question. And we've sort of been in the middle of this major revolution because about 3 years ago, we tried to introduce not just the estimated pricing on our website, but physician-specific pricing. That's the non-negotiated amounts. We would never breach that proprietary interest of showing what Dr. Jones agreed to receive from Aetna, United, or whomever. And we were met with such resistance. We were going to do a pilot in New York, and the Medical Society of New York basically said, don't go there. We're not voluntarily going to help you. And there was really just such blowback. So we sort of held our fire for the moment. So then, just in the last year and a half, we received a sizable grant to bring that level of specific transparency in pricing to our website in New York. And again, let the medical society know this is what we were doing. And they were at our planning table, and they said, we're happy to talk to the press and show our support for this. It was a complete turnaround. We have not received a single complaint. We have over 100,000 physicians listed with their educational information, their clinical affiliation, their hospital affiliation, what their pricing is for the various services. And so that was a really interesting laboratory that showed us, with just a very short period of time, the country has moved with respect to transparency. What that means in terms of the marketplace is interesting, and what we're doing now is we work on the macro and the micro level. On the micro level, we're helping Ann Smith understand what her carpal tunnel surgery will cost. At the macro level, we have a very prominent healthcare economist who received a separate grant to track our data to see, for those services that were offering that very specific pricing, what is going to happen to other providers in the area and surrounding areas. Because a lot of people surmise one way or the other. Some people say, well, if they're charging lower than me, I should go lower so I could get more patients. Or others may say, well, physicians will increase their pricing if they see their neighboring physicians charging more, or maybe it won't change at all depending on what their patient population is. This study is systematically looking at that question to bring just some data points to that conversation so that people are not just speculating.
Well, I've seen fair health repeatedly mentioned in policy circles and in articles talking about the future of sort of healthcare pricing, both at the federal and state level. So keep doing the good work that you're doing. Thank you for being here with us in Texas. Let's give her a round of applause.